Morning, folks. I think we'll go ahead and get started here. We got a good contingent on hand. And I'm John Mulder, delighted to be able to share our presentation with you here for our fellowship lecture series. Today, we're going to talk about conflict de-escalation. One of the things that's been really rewarding as a program director is to observe how our fellows from all the programs have been masterfully handling family conferences. Many of you who are on this call don't have the privilege of participating in the case presentations, but we've got a great group of fellows that really have embraced and understand some of the primary techniques for managing effective family conferences. One of the things that had been mentioned to me, though, was if we could spend a little time talking about when it doesn't go well. How do you de-escalate when families or patients, or sometimes the provider teams, don't seem to be able to see eye to eye? And so I thought that was a pretty good topic. Certainly, those of us who've been in this field for a long time, we know how awkward that feels and how uncomfortable that can be. So I thought I'd put together some things just to kind of help guide us in that. Some objectives. We're going to identify some common sources of conflict in palliative care and to recognize their impact on patient care and family dynamics. And I think probably the core of this is going to be to apply some effective communication and de-escalation strategies to manage and resolve conflicts in emotionally charged situations. These are always emotionally charged. When you start having conflict and discord, there's going to be emotions on both sides of the fence from everybody, including ourselves. We get ourselves involved in those. And also then finally to talk about fostering trust and collaboration, because at the end of the day, I think that if we are able to develop these really strong, trusting relationships, again, between everybody, our patients, our families, our healthcare team, that is going to best support the decision-making process and compassionate care. So I wanted to start out with just a couple of caveats and disclaimers on this. First of all, in the best of circumstances, when you do everything exactly right, when you've laid out the plan, you've got it, you've got the techniques down, you've got the strategies right, it may not go well. There are so many challenges in terms of personalities of the individuals involved, values of the individuals involved, knowledge base of all the individuals involved. There can be a lot of discord, and a lot of times it's really hard to move the needle. So I think that you need to give yourself some grace and understand that even in the best of circumstances, you'll walk out of there and saying, that didn't go anywhere how I thought it might. So you just sort of take a moment, talk with a colleague, reassess, and figure out how you might be able to rectify if there's something broken that needs to be fixed. But so just number one, it doesn't always go well, even when you do everything exactly the way you think you should. The second thing is I really want you to, as we kind of go through some of these cases and some of these scenarios, to take a moment to register your own gut level knee-jerk reaction to that scenario. What is the posture that you take internally when things are going kittywampus, when things are going askew, not exactly how you'd planned? Because there's a couple of things that I see predominant in physician populations when this happens. Number one is to get defensive. We tend to be, we're doctors. We think we're right all the time. At least we think we're right most of the time. And quite frankly, often we are. We have a good sense as to what's going on and what a quote unquote right move might be, given the values proposition of the family and the patient. And so when it doesn't go exactly that well, one of our initial knee-jerk reactions is to get defensive. The other thing that we do probably a little more often, however, is to revert to our knowledge, our medical knowledge and our medical background. And so I just want you to be aware of how you react to these situations and to be conscious about what your strategy, your inherent knee-jerk strategy is to responding to this. Now, certainly there's times when your medical background, your knowledge is going to be a very appropriate part of the conversation. But if you lead with that and you leave the families emotional context out of that, then you're going to find it probably more disappointing. So anyway, just those two little caveats. Let's move ahead. So if we want to understand, excuse me, understand conflict in palliative care, let's start by dissecting the different types of conflict that are out there. And I think there's four primary ones. There's the patient versus family. And these are disagreements about treatment direction, advanced directives, quality of life. We've all seen that where, dad's not sure that he wants to go through with cancer treatment, and daughters, well, of course, they're going to get that chemotherapy. There's family versus family. You've got differing perspectives, old family dynamics, unresolved grievances. You've got, mom always liked you best. You've got perspectives, the veritable, distant relative from California that shows up at the last moment with a different perspective than anybody else does. So the family versus family, we've seen those. We have family or patient versus the care team. And these might result from disputes over prognosis, interventions, the perception of giving up. And you've got perhaps a care team pushing one direction. You've got a family member pressing in a different direction. And so you have a situation in which the patient might feel that the physician doesn't want to treat them, or that they're not listening to them about what's important to them. And finally, there's provider versus provider. And most of us have seen those as well. When there's conflicting medical opinions, there's moral distress, there's lack of consensus on the best course of action. So I want to just spend a moment highlighting a few cases. And all these cases are ones that I've personally been involved in, so it's just real stuff. 84-year-old man with a new diagnosis of metastatic head and neck cancer at the oncologist's office for the first visit with his daughter. I happened to overhear this conversation out in the lobby at a cancer center, and I got involved with the family about 2 weeks later. But at the time of this, the gentleman was musing over his first visit with the oncologist, and the daughter was not in the room with him during that visit, came out and talked with Dad. And Dad said, well, it's about what I thought. A year with, I got a year left if I don't get any treatment, and maybe 2 years if I pursue some sort of treatment, but it doesn't sound like it's pleasant treatment. And the daughter immediately focuses then on, so when are we going to get the port placed? When do you have the when are you getting the all the scans done and everything else? And it's kind of focused on that. Let's get her done mentality. And there's this long pause after which he commented, says, I just want to know how many more times am I going to be able to go fishing? Okay. So now we have a conflict between what's important to him, what's important to her. So anyway, that's I think a pretty classic patient versus family conflict. And I had a chance to then navigate that with them a couple of weeks later when they showed up into the office. I was asked to go out to see a 72-year-old woman, diagnosis of stage 4 lung cancer, extensive bone and brain metastases. She was in excruciating pain. She was delirious, had cognitive decline, and no longer could make decisions for herself. She had 4 daughters, all of whom were out at the bedside when I got to the home. And it was an extraordinarily fascinating dynamic there. This woman had grown up as an African-American in the Deep South and had been discriminated against, had polio, had been refused admission to college because she couldn't walk right and because she was Black. Subsequently, after her husband had left, she raised these 4 daughters on her own, went to nursing school, and made a tremendous life for herself. And now she's dying of cancer. Her daughters were all very, I would say, driven, determined, high functioning. One was a executive VP of a very, very large tech firm, traveled the globe. Another was a PhD university professor. The 2 others were in healthcare. One had stepped aside from her job to take care of Mom. And so all of them had these different approaches. Mom was a fighter. Her whole life was a fighter. She would want to die in the ER, paddles to the chest, everything, because that's who Mom was. And, there someone else said, well, no, I've spent every day with her for the last, year and a half. She just wants to be comfortable. She understands she's not. And so this is what we're faced with in terms of the family versus family conflict. And that was, again, how do we develop an approach to care that respects the primacy of the patient and the validity of the family's perspective? And I think that that's one of the things that I always come back to. It's the validity of what the family feels and what they want, but it is the primacy of the patient. And that needs to always sort of be in your mind as you're approaching these things. This was a 68-year-old man who was admitted for an elective CABG, had complications, and he required a return to the OR, where further complications arise. So within a week after his CABG, he is now had 2 open heart surgeries. He is now vent dependent, never coming off, but he was still cognitively intact and retained decision-making capacity. And he requested extubation. He said, I don't want to live on a vent, never wanted to live on a vent. This was so part-term, and the attending surgeon refused to honor the request. And in fact, this is just one of those really odd things in which it was in the chart where the attending surgeon said, I have invested too much time in this individual to let him go. That was the quote from the chart. So I got pulled in 71 days later to help to navigate this. So he's in the ICU for 2.5 months, not wanting to be there, not wanting this. And we still have conflict with the primary attending team. So family versus care team, that happens too. Finally, and many of you have seen these as well. This was an 89-year-old woman with advanced dementia, hospitalized with urosepsis, infected stage 4 sacred wound, osteomyelitis, now mechanically ventilated. Again, the extent of her dementia, she's not coming off the vent. The ICU team agrees with the family to make patient DNR and begin de-escalation of medical interventions. Neurology says, no, we got to start dialysis. And now you've got family who is confused because they understand what the ICU team is telling them, that mom can't survive this. But they've got this other physician who is saying, oh, no, we can keep her alive and we can help her. Okay. So there you go. Those are the types of conflicts that we see. And you will have the opportunity to get involved in helping to navigate and, again, sometimes de-escalate that. So I want to just jump right into some foundational strategies that we can look at in de-escalation. Now, some of these are going to be second nature to you. When Barb Opperwald did her talks in the fall, she does a spectacular job just kind of outlining these sorts of things. But I think that some of them bear some reiterating here, just to kind of talk about how they fit in this particular scenario. Number one, perhaps the most important, and y'all are good at this as fellows, and that's active listening. Allow venting without interruption. There is such a great temptation for those of us that have background, have knowledge, have understanding, to want to get our points in, get our points across. Sometimes it's because, we have a time crunch. Other times it's just because I know what needs to be said and I just want to say it and get it out of there. But you gotta sit back, gotta sit on your hands and just allow time, allow everyone to speak. You sit and speak, call out someone who may not be talking around the table, but just allow the venting without interruption and to reflect back emotions. I hear you're frustrated. I understand how this could be frustrating to you. One of the little nuances when you use that word understand, and this really isn't, it seems trivial, but it's really important, that we not jump in and say, I understand how you're feeling. Because there's a good chance we don't know how they're feeling. Unless you have personally been in that situation where your mom is on the vent having to come off. You don't know what that really feels like. You can understand how that might be distressing. You can understand how and why, but you don't understand. So just don't put yourself directly in their shoes as if you know exactly what they're going through. So I hear that you're frustrated and I understand how difficult this must be. And then always validate the concerns. Again, I can't imagine how difficult this must be. This must be really difficult. This is such a challenging time. And you do that with statements like that. After you have a chance to walk through that process of just listening to folks and hearing what they have to say and letting them process that, you find the shared goals, establish some common ground. Everybody here wants the best. There's no, there's no dispute that what we want is the best for her, the best for him, and reinforcing that we're all on the same team. We're not adversaries. We're not enemies. We're not, we're on the same team. And we may have at this moment some perspectives of different strategies, but we for sure have the same goal in mind and are on the same team. And again, sometimes it's easy for us as physicians to kind of overstep our bounds and begin either taking sides or putting our own spin on it or translating our own value proposition in there. So we need to maintain that neutrality and professionalism. We need to avoid at this point taking sides, showing bias, and using neutral language. Yes, there are different perspectives on this. We've referred everybody. Let's dig into it. Let's explore them together and see what that might mean, how that might play out. If we decide that this is a rational place, what does that mean for your mom? What does that mean for you? And so let's start talking through that. Now, you're familiar with probably the spikes model and some of the other techniques that have put out there. I only put one in here just as a reminder, the ask, tell, ask method. And we've done variations of this. Just ask what the family and the patient understands. If the patient is certainly decisional and conversant, ask them what they understand about what's going on. Ask the family then what they understand, what they think is going on. And get everybody's input so that you've got a good sense as to what the tenor is around the table. And then you tell them information in simple, direct terms. This is where you then have the opportunity to clarify if there are some misconceptions, if they don't really fully understand or get what the issues are. And then to ask them to reflect back their understanding. This is a great place then to begin reframing statements. And I know that a few weeks ago when we talked about words matter, that phrase, there's nothing more we can do, is something that is not part of this conversation. Our focus will be shifting to, and then fill in the blank. A lot of times that's shifting to a comfort measures, shifting to quality of life, shifting to a plan of care that preserves her comfort and her dignity. And again, the negativism sometimes that can subvert our best intents. The treatment isn't working. To really reframe that in something such as, the illness is progressing despite our best efforts. Again, we want to do what we can to avoid somehow implying that it's the patient's fault that they're getting worse. And that's a danger that can happen when we have this. It's not their fault. They're not failing. They're dying, but it's not because of their failure. It's because this is what they have, and this is what the medical system has for us to render right now. And it's not going to get the job done. And so we need to really shift our efforts to something else. If you're not familiar with this, it's called the BATHE model. Again, everyone seems to have to pull in these interesting acronyms. But again, one other technique that injects a couple other nuances here. The background, again, the same thing. It just as they ask you, what's going on? What do you think is going on? What you've been told is going on? But then it shifts it just a little bit. How is this making you feel? So now we get to tap right into the emotional context of the patient, the family. How's this making you feel? And what is the biggest concern right now? Because in the midst of these sorts of things, when all seems to be crumbling, we have multi-system organ failure, and this is going to pot, and this is going downhill, You know, what's the biggest concern right now? I'm concerned that they told me my mom's kidneys aren't working, and I've seen that before, and it's a problem. Or it might say, you know, she just seems to be so uncomfortable, or she hasn't had anything to eat. She hasn't had bowel movement in 4 days. You know, what is the biggest concern right now? So you can start getting that on the table. And this is a good one too. The H handle. How have you managed this so far? This is a really, really big deal. Tell me how you're coping, how you are managing this right now. And then, of course, you close with the empathetic response. That sounds incredibly hard. So instead of an ask, tell, ask, where you're doing a lot of knowledge basis and knowledge focus, the BATHE model really does a very, very nice job of tapping into the emotional context. And again, I've said that before, I'll say it again, I'm sure, is that if you're not sensitive to this part of it, you're going to miss an opportunity to really help navigate this optimally. So one of the things that we often see when there is conflict is the bubbling up of anger. And so I want to spend a moment just talking about a rational response to anger. The first, again, you acknowledge. Anytime you see emotion, I think it's important to acknowledge. I can see that this is really upsetting for you. And again, I can understand why you might feel this way. Again, not I understand how you feel, but I understand why you might feel this way. When faced with this type of scenario, expecting ABC, getting XYZ, yeah, that makes a lot of sense to me. So, you know, you again, a little active listening, allow to vent, and then you begin to redirect. This is where the problem solving. Let's talk about how we can address your concerns. And so how are we going to manage the situation and the anger in response to the situation? So it's a two-part deal. You got to do them both. You have to address both of those. There is the pause principle. I know Barb had mentioned this. Before reacting to conflict, pause. This says 3 to 5 seconds. It can be however long you feel needs to allow the room to clear of the initial explosion of it. Take a deep breath. Lower your own emotional intensity. There's one of my colleagues, I have a lot of respect for, shared with me her technique for de-escalating her own personal emotional intensity with that. And especially when you have moments of pause, as you may be aware, you know, a lot of our emotional energy is generated from the right side of the brain. Left side of the brain, our analytical side, it tends to be a little more rational. She does times tables. 2 by 2 is 4, 2 by 3 is 6, 2 by 4 is 8, 2 by 5 is 10. And she just consciously does that for a few seconds and finds that helps to bring in a little more analytical and less emotional, and kind of decreases some of the emotional intensity of those moments. So just a very simple little thing. If you're finding yourself wrapped up and finding yourself drawn in to someone else's emotional gain, then shouldn't use the word gain, but their emotional response, then take a step back and reduce your own, so that you can again help to guide them. It doesn't work if you've got people who are on the edge emotionally, trying to negotiate or to navigate these things. And again, using silence effectively. Resist the urge to fill silences with immediate responses. That's skill. And many of us, and I'm guilty of that one, many of us have to practice that one. Silence is okay. It's perfectly fine. It allows the emotions to settle. And more importantly, I think it invites others to speak. We've all been in family conferences where someone's dominating and someone's going to lead the show. We need to make sure that all voices around the table are validated. When we get into these really high intensity situations, I think it's important to set boundaries. Behavior can become aggressive, and we've seen those. I've been in situations where it was physically threatening. And we have a responsibility as guiding these things to set the boundaries and to really rein in some of this. And I think this statement simply like, I want to continue this conversation. It's really critical that we do this, but we have to maintain an attitude of respectfulness here. I understand you're hurting. I understand this is difficult. But we need to pull the reins back a little bit, just take a moment, calm ourselves, and get back into this, because we can't do it with this level of aggression. And again, if someone is monopolizing, I appreciate your perspective. That's hugely important and very, very helpful. Let's hear from others as well. But just some very simple redirecting statements there. And we should always go into these with an understanding that while we may be the point person on this conversation, we have a team for a reason. There are other folks that are part of our team and part of our orbit that we can use to help to mitigate some of these more high intensity situations. If it gets to verbal abuse, threats, or it's no longer productive, you can just simply, call timeout, put a halt to it, get a mediator involved. That might be an ethics consult. It might be a chaplain. It might be a social worker. It might be a psychologist. It might be a pastor of their congregation if they've got a faith structure that has been important to them. But you have to be able to identify when things are getting a little out of control, and when to pull back the reins and saying, we'll need to come back and address this. This has been helpful to get this perspective out. And now that we have an idea of where some of the hot button touch points are, let's take a break and come back and then re-engage. I think that what's important in these circumstances is that there is a caveat that we are going to re-engage. We're not done with this yet because the decisions haven't been made, but we need to change the tenor. We need to change the perspective. We need to allow cooling down, and then we'll regather and we'll hit it again. Excuse me. Cultural sensitivity. We want to recognize how cultural values influence decision making. And I think that we need to recognize our own individual limitations on this. All of us are not experts on all cultures by far. I know how I was raised. I know my considerations, in my family, my circle, within my faith community. I know how those things are dealt with by virtue of being in the field for a while. I've seen how other cultural norms might be manifest within these conversations, but I'm not an expert on cultural sensitivity. I recognize, however, how important that is in these conversations. And so I think that just simply by asking the patients and families if there are distinct cultural, faith-related differences, to ask them how they typically look at decision-making in these processes. And again, that's where you've got a team of folks that can help with that too. But you need to be sensitive to that and to recognize that to be fully effective at this job. Emotional exhaustion of providers, cumulative grief that we experience as practitioners who are often dealing with challenges and loss. Dealing with conflict can be draining. Debriefing, self-care are essential. And hopefully within the context of our fellowship program, that you as fellows are learning your own style of debriefing, self-care. There's some people like to get away, cup of coffee, walk in the woods, read a book. talk with a spouse, partner, best friend, colleague, others who will really help you through exactly the same process, provide some active listening, reflective feedback. And but we can't just keep piling on ourselves and expect we're going to be okay. And since managing conflict is going to be part of our job, I think that making sure that at an early stage we have dealt with how do we step aside from that? How do we just make sure that we're going to be okay in the midst of this? One of the things that I have seen that sometimes takes providers into the maelstrom of this exhaustion is their tendency to own the conflict as their own. They step into a situation where there's family conflict and they sort of forget that's not theirs. That belongs to the family and the patient. It's not ours. And so, yes, they can be tragic, they can be sad, they can be emotionally wrought, but at the end of the day, it's not ours. And we don't have to own it. We have to recognize it, we have to know how to manage it, but it's not ours. And so I think that maintaining that perspective is I think it's a first step in helping us in terms of our self-care. Documenting conflicts. I think that, again, these are fluid types of situations that can change over time. Also, if you're doing this right, perspectives of the family and perhaps the care team will change as well as we bring more information in, as we reveal values, as we go through these conversations. You will see shifts in the perspectives of the family members. And so if you have you have a medical record at the time they're coming into the ER, and you've got wife wants everything done, and that's all you ever have there, and don't continue to document well the nature of the conversations you're having, the movement and the changes in perspectives, then that can foment additional conflict. So make sure that you're keeping good records of each conversation that you have and where everybody is sitting on their perspectives, so that it makes it easy for the team and for other caregivers to be able to stay on top of the latest and the greatest of what is going on with this particular patient. I mentioned this earlier, I'll say it again, it doesn't always work. Even when managed according to best practices, the source of conflict and pain may be so deep that the stress remains. Decisions will be made that you view as contrary to the patient's best interest. Again, each family member brings in their own perspective, their own values, their own baggage. Anything from guilt to anger to, again, unfinished business, things that they wanted to do that they're no longer going to be able to do. That can be distressing to them to see that the end isn't in play. I had a case that was memorable, and we all have memorable cases. It was a young woman, daughter of a guy who'd been in and out of the ICU on vents. He was in his 40s, she was 19. And he had alcoholic cirrhosis. He just had lived a fairly self-destructive lifestyle. And now his body had failed, liver primarily, but kidneys were close behind, and he would come in and then be on the vent, off the vent, on the vent, off the vent. And this daughter was his only decision maker. It was the only one they could connect with him. Initially, it was hard for her to come to the hospital because there was a warrant out for her arrest. She was afraid she was going to be arrested if she came to the hospital, but she did come. Had been essentially estranged from her dad since she was a preteen. And so there really wasn't much semblance of a relationship there, and was very challenging, but we were able to get, again, social work was really critical in this in terms of just helping, how do you navigate helping to make decisions for your dad But I remember at one point it was really clear that he was not going to survive. But she really had an intent on making up for the years that he had abandoned her and that she had abandoned him. And I just still remember the heart-wrenching that she had of not wanting to say, I agree with de-escalation. I agree with ventilation withdrawal because the pain of not being able to be connected with her dad anymore and seeing a glimmer that, boy, if he could come through this, then we could have a relationship. It was tragic and touching. And I learned a lot from that personally, from that case in terms of, you'd say, well, he abandoned her, so what's the big deal, But family therapist once, a colleague of mine years ago said, very simply says, there's nothing stronger than blood. Nothing stronger. And so you can enter these situations that seem obtuse and tragic and not always understand what is the power that is bringing them together. And I don't know that mystery, but I know that the ring of that therapist always rings true. Nothing stronger than blood. So keep that in. So alternative language we can use. We touched on this a little bit a few weeks ago, but I like this thing. What is your heart telling you? Or what is that little voice telling you? A lot of times patients and families will focus on some of the technical details that they have been told. A patient once come into the inpatient hospice unit. The healthy 50-year-old guy, 2 weeks earlier, out of the blue, had a massive seizure. He was in status epilepticus when he came in. They really, they were not unable to break it no matter what they were giving him. And the imaging did show this horrific multi-tentacled astrocytoma in the brain. Because of his condition, he was not going to be able to go through any kind of radiation surgery. And so basically told his wife, there's nothing really that we're going to do here. We should send him over to hospice. And so when he hit the door 2 weeks after this initial event, he was actively dying. And again, kind of I'll ask sort of thing, I asked the wife what she's been told. And she said, well, I was told that most people with this type of a tumor die within 6 to 9 months. That's her expectation based on what she was told, right? Okay. And but clearly that was not going to happen. And so I said to her, well, what does your heart tell you? And she said, I don't know how we could go on like this. So that was a really nice thing to be able to validate for her. I said, your instinct serves you well. So let's talk about what today's going to look like. So use that and trust the instinct of both patients and caregivers in terms of what might be going on there, and use that information. And then the second bullet, what do you know versus how do you feel? Because those are two very, very different things in these situations where someone knows, but it's such a burden and it's so heavy and it's so overwhelming. They have a hard time getting past the emotions of that. So this is when we get into the conversation of hope versus expectation. The hope doesn't require us to know as much. There are things that we hope for that we understand may or may not come true. Expectation, on the other hand, is based on some aspects of reality that we have to acknowledge. And that gets into what is fantasy versus reality. What is it you really, what do you hope? Well, I hope that my dad would live long enough for, to make it to his grandson's graduation 40 years from now, and that's not going to happen. So what's the expectation? What is the fantasy versus reality? These are often good times to begin injecting the opportunity for reflection. When you look back on these days, what would you like to remember? Now, this is different than, what is the legacy of your dad, your grandpa, your spouse? But as you think about this moment, when this transition is going to happen, death is the reality here. What would you like to remember? How would you like this moment to be remembered? And that's sometimes a very helpful perspective, because I think that one of the universal things that we see, nobody wants their loved ones to suffer, right? Nobody wants to be in pain. And a lot of times when you ask this question, I would like to remember that dad was at peace. I would like to know that he was out of pain. I would like to know that this was that he was, however they want to create a metaphor for being, laid in the arms of his Lord and Savior in a quiet and a peaceful manner. How do you want this to be remembered? And then that gives you an idea of how you can help them play it out. Again, death is a reality here. So I think that keeping that in mind, and again, we talked before about the if-whens. A lot of times, if death is not, when death occurs, what should this look like? So just a few ideas to facilitate conversations around and about transitions. Again, we're inviting the conversation. We're not going to force our agenda. If the family's too emotional about the bad news, give them time to grieve before moving on. Again, this may be just simply stepping away. If they're having trouble deciding what their loved one would want, give them space. Sometimes, and I'm kind of, when I put that bullet up there, it sort of struck me for a moment, because, my dad died of cancer 45 years ago. I was a young man. I was still in medical school at the time. And as I typed that thing, I said, I don't know that I knew what my dad wanted. Certainly that was not an era in which we were talking about, values-based palliative care that existed at the time. And I'm just overwhelmed as a medical student trying to take in what the doctors are telling me. Some making sense, a lot not making sense. But dad was not a talker. He was a pretty stoic individual and not very free with his emotions. And so we didn't always know what he felt or thought. And so this one gave me pause. And it might have been helpful somewhere along the line to have some conversation with family about that. Someone would have been able to facilitate that. Anyway, sometimes a helpful question is, could you tell me what you are thinking about right now? And again, that's a nice little opening to allow someone to tap into how they're reacting, responding to this, and is going to help you in terms of pursuing the next level of conversation. Again, respond to emotion, especially hope. Some surrogates perceive withdrawing or foregoing treatment as giving up hope. Hope can be directed toward many things. It can be helpful to direct the family toward other things for which they can hope in the context of their loved one's illness. Again, from a slide or two below or before, thinking about how you want this to look as you think back on these days. What is it you would hope could be accomplished in this moment when this transition through death occurs? And I think before redirecting hope, it's really important to acknowledge the importance of what has been lost. There's a grieving process that begins long before the actual death, and I think we have to continue to acknowledge that. Often there are these feelings of guilt, feelings of responsibility. My mom would have never wanted this, but I cannot tell you to stop. I want her to get better. Right in that moment, they're telling you what the patient would want, and thus the right thing to do they're also telling you they feel pretty guilty about this process. And are reconciling, again, nothing stronger than blood, that as a child, how can they do that? And again, important for us to acknowledge that this is a difficult decision. And you don't expect them to make the medical decision. We expect them to tell us what they would want, and then we make the medical decisions based on those values and those testimonies. That's, for example, comment might be, I don't expect you to tell me to stop. That's not what daughters say. Your job is to tell me what your mom would want. My job is to say, based on what your mom would want, what should be done. I see how hard this is for you. And I don't want you to feel like you're responsible for making medical decisions for your mom, or more to the point, that you're responsible for your mom's life or death. Because some people will take this, mom died because I told them to do this. As if I didn't tell them to do that, she'd still be alive, which of course is not true. So how we frame those is important. Always affirming the commitment to the patient, the family. I'll stick with you through this. The nonverbal commitment, look them in the eye, return their phone calls, help the family work through the systems of care, keep your damn phones in your pocket. Demonstrate non-abandonment by being willing to be with patients and families who are distressed. That's a powerful sign of commitment and caring, willing to be there, and to simply be present. A lot of times, I sometimes just drill down and say, as physicians, we have a couple things to offer to our patients and families: our presence and our provision. We tend to focus on the provision. What are we going to prescribe? What test are we going to order? What procedure we're going to do? What's the next tangible step in the providing of something? But I would just like to affirm that for many of our patients and families, the most important thing we give is our presence. And that speaks volumes. And the families understand that, even when words are not necessary. So always presence. And again, mentioned this a couple times, bears repeating, give the family time to think about what you said. This is a big deal, and they may need some time to come to grips with the information. Better to let the family sleep on the information than pushing for a decision today. Remember that transition conversations, they're really two conversations. Number one, hearing that things are not going the way we wanted. That's number one. That's not what we had expected when we came into the hospital. Number two, coming up with a new plan. And here's the deal. Some families have never considered that their loved one would get worse and that they would need to think about what he or she would want. And so that's an important consideration also. But they've never contemplated that. Dad's always been dad. Mom's always been mom. She's always been here. It never occurred to me that she wasn't going to get better and come back home. It's not going the way we wanted. We need a new plan. Encouragement, praise is always useful, worthwhile. Clinicians tend to focus on what the patients and families are doing wrong, or what they're not doing, or what they could be doing, or how what's happening isn't the right thing for the patient. During a time the families are feeling vulnerable, it is really important to build the alliance. Again, we're talking about building trust here, by recognizing explicitly what they are doing well. I can't imagine how well you've done this. You've been here every time I've been here to round. I see the sacrifices you're making on behalf of your dad. And I can't tell you how much I admire that and what a blessing that is for your dad. I mean, really important to affirm that because in many cases, remember that what does your heart tell you? What is your, what's going on in your mind? They instinctively understand that things are not going well. And there's this fragility that in many circumstances might lead them to believe that somehow they should have done something different that would have made a positive difference. You need to affirm that what they're doing is good. When we talk about, again, therapeutic or supportive dialogue, again, Mention this to distinguish your emotions from those of the patients in dealing with intense conflict. Take a step back, identify your own emotions to yourself, and try to describe them, not display them. Try to find the area of conflict that is unresolved that's making you feel distressed about this. And try to obtain agreement on the area of difference, even if it can't be resolved. These are internal conversations that you have with yourself. Why am I feeling this way in this particular circumstance? I alluded to my dad's death many decades ago. And I can tell you that decades later, if I'm in a room with a 50-something-year-old man who's dying of cancer with teenage and 20-year-old kids around the bed, I'm transported there immediately. I am reliving my emotions 45 years ago. And I need to reconcile that. And I cannot allow that to influence conversations I have with family. Because is that going to unwittingly pull me into suggesting things that I wish I would have done or could have done with my dad? So when we talk about identifying your emotions and reconciling them, that's what this is all about. Just make sure that you're not allowing that to creep into the conversation with the family. Mentioned this earlier, mentioned again. The patient has primacy. A mentally competent patient has the right, ethical and legal, to determine who shall be informed about his or her medical condition, what should be done. The family's feeling has validity. It's important to the professional to identify the family's emotions, acknowledge them. For this purpose, the empathetic response has great value. We talked a bit at the front in the various types of conflict about conflict amongst the care team. I got to tell you, my observation: doctors aren't that great at communicating with each other at times. It's improved by maintaining continuum the continuity of providers, but it becomes challenging sometimes in the era of medical care that's provided in hospitals, in which we have different teams shifting, we have different attendings shifting, and there's this almost a revolving door sometimes. And so it's really, really important that we take an extra step forward to make sure that there is unanimity of information that is being transmitted, that if there are conflicts that are appearing in the chart, that we don't just negotiate that in the chart, that we actually talk with doctors and we say, this is what you said, this is what your partner said yesterday, and this is what we're seeing today. We need to bring some resolution to this. And so don't allow just words on a page in an electronic medical record to be the way that the physician teams communicate with each other, and take some role and responsibility as a palliative physician who has expertise in communication skills to try to reach out and to reconcile what you're seeing as conflict between the docs. A lot of times when we're doing this with docs, am I addressing the right person? What do I know that the other doctor should know that they may not know? And a lot of times what you know comes from the conversations you have with patients and families regarding the values proposition. And that's something that you almost always are going to be on the front lines on, that other providers may not. So what do I know that the other doctor should know? What does this decision or this particular circumstance mean for the patient's future? Who's going to do what? If there is going to be, for example, a withdrawal, is that the responsibility of the ICU team, the pulmonologist, the palliative team? Who's going to do what? And who is the coordinating doctor who really is on point, which may be different than who's listed as the attending in the chart. And again, how shall we communicate again if problems arise? Hey, if this happens, please give me a call, give me a text, shoot me a whatever. But we need to make sure that the doctors have some unification on these when these critical transitional issues are at stake for the patient family. If the doctors are out of sync, it's going to play out poorly with the family. So I'm just going to close with just some pitfalls. Don't give pathophysiology lectures. I mentioned at the front end, sometimes one of our reactive postures as physicians is to do that. Don't do that. It doesn't help. Ignoring the context of the communication encounter. Don't force your agenda. If the family's too emotional about the bad news, give them time to grieve before moving on. I mentioned that a couple of times. That's because it's important, so I say it again. Another barrier, if you're not finding out about the family's information needs, their styles, their communication processes, their language, their lingo, their vernacular, you need to know that if you're going to be most effective at connecting with them. Asking for the family member's information needs allows them to some control of the situation. In addition, and occasionally, people are emotionally unprepared to hear certain information. They'll tell you that before the show. I just can't handle any bad news right now. Okay, well let's talk about what's happening here, and we'll get to where we need to be when we need to be there. Launching into your own agenda first without negotiating the focus of the interview. Be clear you know what both you and the family want to discuss. Offering reassurance prematurely is a danger. Resist the temptation to make things better, for example, rushing to suggest that things might get better, or, there's a chance, Dumb and Dumber line there. So you're saying there's a chance. Also pushing the family to make a decision before they've had a chance to grieve the loss. Remember that when people are emotional, and I'm going to put ourselves in that same category, we may not be thinking clearly. So make sure that we're reconciling that. So also, I don't want you to feel that somehow you're responsible for maintaining the patient's hope. Hope is not something that's ours to give or take away. People have their own inner resources. We can help to guide them. We can help to frame. But I'm not responsible for someone else's hope. Ignoring your own feelings, again, that sometimes people think that that's a noble thing, just to ignore your own feelings. I think it's potentially hazardous. So make sure you're in tap with what you're feeling about a particular circumstances. I would avoid making assumptions about what the family knows and doesn't know. And I would say that one of the dangers that we sometimes see is when we as practitioners are dealing with families that have some medical background. Doctor, nurse, someone in the family has some medical background, and all of a sudden we jump to some conclusions about what they may or may not know. Don't do that. Just presume that they don't know much, and then help to catch them up. They'll tell you yeah, we got that part. Okay, great. Let's move forward. And finally, talking too much. Again, silence, pauses, really, really, really important. So again, one of our knee-jerk responses is sometimes offering more aggressive care. These conversations may be distressing to families. It may be just easier to offer more treatment, right? That's what we as doctors do. We're trained to identify broken things and fix them. How do we fix them? By doing more things. This might temporarily calm someone down. Well, we could do this. Yes, that nephrologist, we could start dialysis. It may calm everybody down, and it evades the real issue, doesn't it? And in the end, you still have to have the planning conversation. And even if you agree to more treatment, you still need to talk about what's not going well, the likelihood they will not improve. And this means learning to empathetically respond to the family's emotions. Talking about procedures like EPR before discussing the big picture of disease status, where people come in, well, do you want to be full cold or not, or DNR? You need to talk about disease status, patient values, wishes, all these sorts of things you need to reconcile and talk about before you talk about what types of things you are or not going to do. Patients will pick up on the verbal and nonverbal cues. So be aware of that. Watch yourself for distancing behaviors. A lot of times physicians, when they realize that patients are not going to survive this event and they are going to die, physicians will instinctively withdraw. And so make sure that you are embracing that moment. So we'll stop there. I'll pause here for some questions and any comments that anyone might have.
Hey, John. Ken Hansen.
Hey, Ken.
Do you have a reference to that BATHE? I'm not sure I have seen that before. The BATHE model for emotional processing.
I do. And I tell you what, I will put that into the PowerPoint before I post it.
Great. That would be fabulous. Thank you.
So you can pull the PowerPoint out of the YouTube channel later today, but I'll put that I'll put that reference in there. All right. Well, thank you for your time and attention this morning, and you all have a wonderful week.